Hi everybody. Good morning again from Third Park Hospital in Nairobi, Kenya. Today we're going to be talking on a separate topic about operative hysteroscopy. Now, operative hysteroscopy is something that has evolved over time. And if I look at the evolution of hysteroscopy, it was started off as initially diagnostic hysteroscopy, and then it moved to simple operative procedures like polyps and retrieval of lost IUCDs and diagnostics plus maybe sometimes biopsies. But then after that, it went to advanced operative. So why is operative hysteroscopy something we need to understand? The reason is, number one, there are very many pathologies in the uterine cavity that we should know about. And there are very many symptoms that these pathologies will cause, ranging from abnormal uterine bleeding, to fertility issues, to pain, to very many other different symptoms. And operative hysteroscopy is something we need to understand because it's very challenging. It has a very small cavity to operate in, and this is a potential cavity that needs to be distended with some distending media to actually operate in it. So it's not like laparoscopy where this is a whole big cavity for us. It's a small place, so it is quite challenging. To name a few procedures that we normally would do with operative hysteroscopy, we would say we have polypectomy, we have biopsies, and that would be ranging from situations where we have endometrial hyperplasia to miscarriages and biopsies to rule out the cause, sometimes to recurrent pregnancy losses, sometimes to postmenopausal bleeding or thickened and irregular lining, to an Asherman's where there is synechia and related issues, to septum resection and metroplasies of different types, a niche or an isthmosil, a caesarean scar lesion, site niche. Myomectomy can be a surgical procedure, cervical stenosis and block and collection of fluid inside, to endometrial ablation. And there are others like cannulation of the proximal end of the tube, insertion of Assure has been done in the past, IUCD removals, pre-IVF, endometrial scratch, etc. These are just to name a few. So we want to go into the different levels, and the different procedures one by one. So in terms of the various procedures, actually, we would say that not all procedures fall under one level. So we have levels of the hysteroscopic operative procedures, and as per the RCOG, as one of the guidelines that we can come across, we have level 1 procedures like diagnostic hysteroscopy and targeted biopsies, to small polyps which are pedunculated, to removal of a lost IUCD. Level 2 gets a little more complex where there is proximal tubal cannulation. We have minor synechia and Asherman's to a type 0 myoma, and also involves removal of a large sessile polyp. To level 3, which is now more complex and requires specialized training, which is septum resection, to major Asherman's procedures, including myomas type 1 and 2, and endometrial resection and ablation procedures. So these are just a simple way of stratifying the levels of different operative procedures in hysteroscopy. Now, what are the issues we need to know about operative hysteroscopy per se? Well, it needs advanced training and a very high level of expertise. I told you it's not that easy. Operative hysteroscopy with the small cavity is something we need to look at, and this requires additional training. We also need to understand that operative hysteroscopy ideally will need some sort of dilatation. Diagnostic will not, but operative could. There is increased risk of intravasation and fluid challenges. The view can be an issue when bleeding starts, so we have to make sure that that is taken care of as we're operating, and it's not going to disrupt our procedure. Stratification can be a challenge, which means what can be and cannot be done by a specific surgeon is very difficult to stratify and to guide. You can't police what someone does and does not do, but I think it becomes a self initiative, and conscious should tell us that I think this kind of procedure may need additional specialist care, and I could refer them to somebody else to do them. It's probably beyond me. Selection of cases can be a challenge. Therefore, is it that you cannot do it, but you tried it? Or is it that you were probably not able to select properly because of a diagnostic error, and therefore you went in and only realized that it's now more complex than we thought? And we have to understand that in operative hysteroscopy and in all hysteroscopy procedures, there's no one you can blame. It's a one-man army. It's you who is the camera person, and who is the operative surgeon, and who is the one doing the whole procedure. Unlike laparoscopy, where you would have your assistant and your camera person who is probably helping you, and a second assistant if need be, and you're the surgeon. So you have enough people to probably throw your little blame on and say that I think it would have been better if my camera person was like this, or if my assistant knew what to do. Well, that doesn't happen here. It's a one-man army. You are doing everything yourself. Let's start off with the first procedure, endometrial biopsy. So a few tips and tricks as per what I would do, and obviously this is my personal procedural guidelines. Number one, there are three ways of doing this. We could have a punch technique where we would hold a tissue, crush a tissue with, let's say, a tissue with some cavity and a spoon biopsy forceps, for example, or punch biopsy forceps. Hold the tissue and retract it. And you would get the tissue within the forceps handles, and something of this sort. The second one is grasp technique. So you'd hold the tissue, you would detach it, pull it from its attachment, and then come out with the scope. And this is probably a better way of doing it, because you will probably get bigger tissue pieces with this technique than with coming out through the instrument channel. So you have to understand, you hold, you would grasp and separate it out, and then come out with the scope together, which is the ideal way of doing it, so that the tissue that you've held might be bigger than the one that can go through the instrument channel, and you will still be able to get the tissue better. And the third one is hold, twist, push, release, hold, twist, push, release, and free bigger tissue as you move on from the endometrium for biopsy. And then once you've freed all of it, hold and then pull out with the whole scope together. So this is to get a bigger sample from the endometrium than with the first two. So hold, twist, push, and continue doing that to get a bigger chunk of the tissue until you can free it from there. Obviously, to increase reliability for endometrial hyperplasia, I preferably do this procedure in the proliferative phase, when it's a bit easy to see around. It is important to do an eye-directed biopsy, so it's always not good to do a blind biopsy. You look at the tissue with hysteroscope, and you actually can see which area you're targeting and remove it. Video record all your procedures and appropriately document all your procedures. Let's go to retained products of conception. So, retained products of conception are usually very friable tissue, and using a cold loop, trying to scrape them off, is probably better than to use electrosurgery with energy, because you're likely to damage the endometrial lining, and including the basal layer, and probably go even into the myometrium. and that could be a problem. So unless these retained products of conception are actually stuck to the myometrium, which means they're going into an accreta format, I don't think you need energy to separate it off. So preferably using a cold loop, scraping it off, and then separating it away, and then using the regular way of clearing it off the cavity with either a suction cannula or letting it flow out with the hysteroscope is acceptable. Caution, always check and rule out an AV malformation with prior Dopplers in cases of retained products of conception, as this could lead to massive bleed when you open these vasculature channels up inside the cavity. Because when you have retained products, or sometimes following a history of dilatation and curettage or suction evacuation, with the healing process, you may get an AV malformation that may have formed. And this is not going to be easy to remove with hysteroscope. You may start bleeding torrentially. So be extremely cautious about that. Make sure you've done your Doppler flows to check this area before you've removed it. It's also important maybe to check the beta HCG and make sure that this is not actively proliferating tissue, and it is probably just dead tissue that is remaining. Now we move on to polypectomy. So polypectomies or polyps can be divided or described into, these are endometrial overgrowths, but they can be described as sessile, which means they have a broad base, like this one here. Or it could be pedunculated, where they have a narrow base and it's free floating. Or it could be a single polyp, or it could be a multiple polyps inside the cavity. It could be a suspicious polyp. So there are different types of descriptions on polyps. Overall, they're diagnosed and confirmed by ultrasound, preferably transvaginal scan, and with a good resolution machine, I think it's quite easy to pick this up. But they can be confirmed further by saline infusion sonohysterography, or SSG, SIS, same thing. So you can confirm that, where you now instill saline as you do the scan transvaginally, and with the fluid distending the cavity, as you can see in this clip here, you can easily pick up the polyp and its attachment and all the details. An MRI has also been used to inform and diagnose or confirm polyps. How do we remove them? Polyps can be removed using graspers, using scissors, using a resectoscope, using a morcellator or a shaver, and also laser has been used. So the tips. If it is small, you can work differently from when it is a large polyp. One of the tips is, please understand you have to remove it completely from the base. Just cutting it off, leaving the base, will only mean that it will reform and regrow over a couple of months to years, and you will get a recurrence. When it's a large polyp, work on the surface of the polyp and away from the stalk, going towards the stalk. Don't be in a hurry to cut off the stalk. You'll have a polyp floating in there. They'll be very difficult to now capture and remove. If it is small, you can work from the base. So if it's a finger or a polypoid, pedunculated polyp, you can hold the base and then you will be able to remove it from the base. But if it's a larger one, you have to make sure you work from the tip downwards as you remove it. If it's large, you can bisect it or quadrisect it to remove it. So work on one half, cut off, then, or if it's very big, quarters. So you remove this quarter, remove the next quarter, remove the next quarter, and the last quarter as you get to the base. Remember to hold the base and push, not pull. So if you want to remove it totally, you don't hold and push. You hold the base and push, then hold again and push, hold again and push until you separate it off if it's a small polyp, and then pull it out with the whole hysteroscope coming out together. So that is hold, push, not pull. Preferably do it in the early proliferative phase, when I would say when the endometrium is thin. So how do we look at it? For example, I am in Kenya, and Kenya is well known for safaris. So when we go, for example, to the Masai Mara, and we go there to look for animals, if you go there, you could go in 2 seasons. A season when the grass is very tall, because there was rain and it's growing, and a season when the grass has been cut or taken off, or it's short. Now, when you go where the grass is tall, you could have a lion sit next to the road and you'll miss it. Why? Because the grass is camouflaging it and it's hidden in the grass. And when you go in to the Mara, when the grass is very short and cut, you could be on the road and you may be able to see a lion that is probably 50 meters away. So in simple words, going into the endometrium when the grass is short in the proliferative phase will allow you to see the pathology and remove the full pathology, as opposed to going in the second half when the grass has been grown tall and it will hide away some of the pathology and you might miss out on removing it. So early proliferative phase for polypectomy would be an ideal situation. Going in vaginoscopic with or without pharmacological cervical preparation makes sense, as opposed to physically dilating it with dilators, because you could have your dilator create a false passage or dig into the posterior endometrium, and it will disrupt the appearance of the endometrium and camouflage or hide the polyps away, because your dilatation has damaged the endometrial lining already. So as I've said, the different options would be removal with a resectoscope with energy in large polyps. It's very easy to remove it with the graspers and scissors when they are nice and pedunculated. It becomes a bit more challenging when they are long and sessile and large. But one of the best approaches would actually be the shaver or the hysteroscopic mocellator, and there are various types. We have the IBS from the Stodes, we have the Myosure, we have the one from Covidian. So basically speaking, there are a number of ways we could remove these by the shaver. So these are some of the ways to remove the polyps. Let's go to Asherman's. Intrauterine synecdoche, major issues, and not an easy way to, or not an easy condition to handle. These are intrauterine adhesions consequent to trauma to the endometrium, diagnosed by an HSG where you would see interruptions in the X-ray. SIS can be used to confirm and diagnose it. Ultrasound transvaginal is sometimes enough to see the irregularities and see the Asherman synecdoche. MRI or actually a diagnostic hysteroscopy could confirm it. What are our aims in an Asherman's procedure? Number one, it is to restore anatomy, to restore the endometrium to become functional and grow again and have periods, to improve or retain fertility, to improve menses, because most of these women would actually have hypomenorrhea with reduction in flow to almost no periods. So very scanty flows, and you want to improve the menses. And you have to make sure that our goal of prevention of recurrence is kept into mind when operating in Asherman's. There's no point doing a surgery and the next thing is the next month it is back to adhesions formed again. So we'll have to figure out how to prevent that. So the management is basically in the form of synecholysis or adhesiolysis, in simple words, with the restoration of the cavity as much as possible, prevention of recurrence, and second look. Sometimes or most times is needed in advanced Asherman's to ensure that this is corrected appropriately. How do we do it? There are different ways we could do it. Cold scissors is one way. Resection is with energy is another way. Using just an energy bipolar needle is another way. And using a shaver could be also an option, but you may need to get space to get into the cavity to use a shaver. So these are different ways we could actually approach Asherman's syndrome. What are the issues with consent? It's important to understand and discuss these with the patient. It is likely to be a long procedure. There is a risk for perforation because in Asherman syndrome, you could easily divert off into a false passage and actually get into a perforation scenario very easily. So you have to be discussing this possibility, but reassuring her that it should be something not to worry about and we can handle it, and it depends on the tool that actually perforates. But that if that happens, we might end up with an incomplete surgery and we might have to do it at a later dating. We might need a resit surgery. Many of these procedures may not be complete in one sitting. So you may have to explain to the patient that a resit surgery might be likely, and there's nothing wrong with that. It's just that I'll complete this procedure in bits, so that you don't have too much damage done in one procedure. I might also discuss with the patient that we might sometimes have to do concomitant lap with it. So what does that mean? You have a double setup. You're doing hysteroscopy, but you have a laparoscopy view as well to ensure that you're not going to go into the wrong place or perforate. And if you perforate, then it's captured and you have all the evidence to ensure that you did not injure anything else outside the cavity. And it's also possible to avoid this by doing it under ultrasound guidance. So you're doing your procedure, whereas there is an ultrasound probe from the anterior abdominal side that could guide you that you're where you are, so that you're not leaving the endometrial cavity and going into the myometrium and coming towards the serosa for a perforation. And it's also important to discuss that there is a risk of recurrence in these conditions, but we will take certain necessary measures to avoid recurrence. What are the challenges about an Asherman's procedure? Number one, while you're doing it, it's likely to open up vascular channels, and with this, there is a risk for fluid overload. So you have to be careful and have someone who is constantly keeping a tab on the in and the out of the hysteroscopic fluid, of the distancing media, to guide us on when to stop. And obviously, as per all guidelines, we know that a deficit of 2.5 liters of saline is immediate interaction to stop the procedure wherever we've reached, and maybe consider a second look later, but you don't continue. And similarly with a liter of an hypotonic solution if you're using monopolar resection by any chance. Although nowadays, I think with bipolar resectoscopes, it's very rarely that we would do monopolar because of the fluid challenges in that condition. Anatomy is usually distorted, so there's an increased risk of false passage and perforation, so that's a challenge. And many times it may need a second sitting to complete the procedure, and there's nothing wrong with that. It's not a complication, but it's a challenge, and this should be well communicated to the patient from before. Tips of surgery from my side: go in vaginoscopic, don't forcefully dilate, dilate under vision, enter under vision, cut the synechia under vision. Most of the synechia, if they are adhesion bands, would be not having very high vascularity, but as you get towards the walls, you may get vascularity channels with it. Try and keep anatomical landmarks always in constant view. So know your landmarks, know how the internal cervical canal should look, know that now I think I am at the internal os, this was the external os, know that this is looking like I am within myometrium, so it guides you. It will give you guidance. Keep the ostia under vision. Make sure that your aim is to bring it to the same level. So basically speaking, having certain anatomical landmarks is very important. So in the discussion on anatomy of a hysteroscopy, we have covered the major landmarks that you should be keeping in watch whenever doing a hysteroscopy. And I think that's important to guide you through this procedure. What is the end point? When do you stop resecting or cutting or shaving or whatever? Well, when you start reaching a point of bleeding with some pink when you cut, you're most likely into myometrium. So because synechia within the cavity is likely to be avascular and will not be pink, will mainly be white. So you can use that as a guide, and that experience will tell you. When you get both ostia at the same level, you don't need to go further up because you're likely to then go into the fundus, myometrium, and then risk perforation. Be very careful near the ostia. It's usually very thin there because it's very easy to perforate at that point. So these are some of the endpoints that you need to keep in mind. When do you know you have a false passage? Well, when you have myometrial fibers with bleeding, I told you, then you have to be very clear that I think I am in a wrong place. This does not look like the cavity. It does not look like synechia. It now looks like myometrial fibers. And how do you check it? When you're going on, if you think you want to assess with the hysteroscope, just close the channel of the inflow. And when the fluid is going in, if you close the channel of the inflow, the pressure within the cavity drops because you've stopped the fluid going in, and the outflow is still open. So you will see the fluid inside now reducing, and you will see bleeding points that will start. So if there's a lot of bleeding points that you see this area is just bleeding a lot, then please understand that you are into a place that's vascular, and it's unlikely to be synechia you're cutting. You might be in myometrial fibers. So be very clear on this, know how to check this. Prevent perforation, how would you do it? Well, you can use concomitant lap in a double setup or do it under ultrasound guidance. So these are the tips of Asherman's. Adhesion prevention. One of the key areas of struggle is to keep the uterine cavity patent, open, and not stick again after you've done an Asherman's or in any other procedure that for that matter, but mainly Asherman's because it already began that way and it has a high risk of reclosing. So one of them is maybe an IUD, but not the regular copper T, because copper causes inflammation and would actually attract more adhesions again. So if you have the LIPIs, which nowadays I know we don't have, it's an inert IUD, or you can use the copper T, but you remove the copper. You remove the copper and just put in the silastic base. If you put that, then maybe it might work, but you don't leave it with the copper. In Foley's, I've used a size 8 or 10 French with not more than 2 to 3 ml and leave it for 5 to 7 days. Hyalo barrier gel, so hyaluronic acid gel is also available and has been found to be quite good in keeping the adhesions from recurring. Amnion graft has been used in the past, and try and ensure if you can to give estrogen and progesterone sequential to allow regeneration. So I have used drugs like Progainova and Provera in the second half to allow regeneration. And probably consider, if you're considering a second look, then when should we do it? I think at least with a gap of 6 to 8 weeks following the initial procedure. So not earlier than 6 to 8 weeks of the procedure, you could actually go in and relook at the cavity. So that's the Asherman's covered, and I have had some extreme cases where I've had to do it in 3 sittings. But then, yes, the patient did eventually have periods and did get pregnant. But unfortunately, with the scarring, there were issues with the pregnancy, and she did have a loss of the pregnancy in the second trimester with an IUFD. So there are challenges with pregnancy following an Asherman's procedure. If you have still left the scarring, you have created a cavity, but there are patches of damage of the endometrium. It could be a challenge still for them to carry such a pregnancy, because the placentation will be impacted when it sticks to a scarred endometrium or a damaged basal layer, or you might end up with a morbidly adherent placental issue like a creta, per creta or in creta. So basically these are issues that we have to be very careful about and warn these patients about it. Now let's discuss septum or uterine anomalies. So which anomalies are usually corrected hysteroscopically? I would say I have corrected complete septum, partial septum, a T-shaped uterus by doing a lateral metroplasty, an infantilis uterus or a Roberts uterus. Which ones normally are not corrected hysteroscopically alone? Then it's biconvex uterus, didelphys, or maybe an accessory cavitated uterine mass, acum, or even sometimes let's say a cystic adenomyoma. It's a bit difficult to do it only hysteroscopically. You may need a laparoscopic element to correct these if we have to do it. Tips about these septum and metroplasty procedures: you can use scissors, cold scissors, you can use bipolar needle, a Collins knife with the resectoscope as all options. Keep the tubal ostia in view at all times. So while you're doing the resection of the septum, keep the tubal ostia in view at all times. Usually the septum happens to be not that vascular, and as you cut it in between the anterior and posterior wall, you start from below upwards, with your target being the ostia at the same level on the panoramic view. And many times you realize as you cut it, it recedes into the myometrium and the cavity actually reforms. But there is obviously the discussion and option of resecting out the whole septum as opposed to just cutting it and letting it separate out. I have been doing the cutting it and incising it, and it separates up and gets pulled into the myometrium, and I think the cavity does retain to be pretty good. In a T-shaped uterus, you can use lateral metroplasty, the home DEW technique, that is the hysteroscopic outpatient metroplasty to expand the dystrophic uterus. So it will be basically the T-shaped uterus will basically mean you're cutting on this side and making it lateral towards the other ostium, and this side to make this T-shaped into a V shape. So I think that is important. Again, a bipolar needle, a Collins knife, or a scissors could be used for the same procedure. In a partial septum, first of all, it's important to differentiate it from making sure that it's not a biconvex uterus you're trying to correct. So a 3D ultrasound or an MRI is the ideal modality of diagnosis that can be used to differentiate sometimes septum from a bipolar uterus. And then once you've made your diagnosis, we're discussing mainly about how to correct this. It will be by fundal snipping to the level of the ostia, because sometimes these also can impact and cause early trimester pregnancy losses. Isthmosil, or a cesarean scar niche, or a defect. This is a defect in the anterior wall of the lower uterine segment or near the internal os, that is near the previous cesarean scar site. So It could be in the lower segment, or it sometimes has been found to be very low near the internal os, because it depends on where the cesarean scar was given. So if you go very close to the cervix, and this usually happens in those patients who probably need a cesarean in an advanced stage of labor or in second stage, you invariably end up going too low, because, and then when it recovers, you will realize you actually cut the upper part of the internal os that had dilated. So important to know that. They usually present with symptoms such as abnormal uterine bleeding with postmenstrual spotting, dyspareunia, pelvic pain is an option, or symptom that they might see, infertility sometimes, dysmenorrhea, and sometimes it's completely asymptomatic and you may not need to really correct it. What are the risk factors leaving it that way? Well, for it to form, number one, it has been found that multiple cesarean sections is a risk factor for it to thin out, and that is a niche there. Short operative time, so when it's done very quickly, it's very likely that you might actually, take too much of the decidua into the closure, and it will end up that way. Cervical dilatation before the cesarean, so as I've said, a higher chance of it happening when you're in advanced labor than in elective planned procedures or procedures that are done a bit early, when there was already a premature rupture of membranes, and taking the decidua in the closure. So when you close the cesarean scar site and you've taken the decidua in it, you have a higher chance of ending up with a niche. Treatment options range from medical, like the combined pills to stabilize the bleeding irregularity, to tranexamic acid when necessary, to maybe levonorgestrel IUS like the Mirena, but usually this is not very effective. Or we could now do it surgically, and we have options of correcting this by laparotomy, hysteroscopically, laparoscopic, or sometimes vaginal by opening up the anterior fornix, and then separating off the bladder and correcting the lesion. So these are all options that we could do. We are discussing hysteroscopy, so let's focus on the hysteroscopic of repair. This can be done using a bipolar resectoscope, but usually 0 and 12 degrees. As we know, operative hysteroscopy, by the way, is preferably done by a 0 or a 12 degree scope as opposed to a 30 degree scope, which is mainly used for diagnostics hysteroscopy. 4 parts need to be cleared as per certain studies. You have to understand there is granulation tissue inside the isthmosal, which will need to be cleared. There will be fibrotic tissue of the proximal area up there where there was the scar site. There will be small caves within the isthmosal cavity, which will be like into the surrounding myometrial tissue. You'll have to get them out and then excise the isthmosal itself. So ideally, one of the steps to convert an isthmosal like this into a flat so that there is no collection of fluid and there are no crypts here with granulation tissue and caves is important, that you first start with resecting the gradient of the distal end of the cervix, so that's this part, and after you've done the distal part, you would now need to go into the niche itself and excise that, making sure that you diathermize the base and the sides of the isthmosal. So you have to go into the sides as well. It's not just a central thing, it's along the whole scar. So you'll have to start with the distal, then the niche itself, and go in and lateral and clear all that hysteroscopically, shaving it as we move, and then go to the proximal part of the isthmosal and smoothen it so that the swelling that is like this is now going to be a smooth curve, and that way you will prevent the bleeding irregularities in these patients. You could do it laparoscopically. So laparoscopy is excise and use fresh repair using sutures. So the steps are basically dissecting of the bladder, noting the scar defect, opening the scar defect, excising the scar defect and niche end to end, so it's not only a central thing, and then repair it with a sound or a dilator in the cervical canal, not ideally bigger than a 7 Hegers size. Avoid taking the decidua during the tips of surgery. Avoid taking the decidua. Do it vaginoscopic if you're doing it obviously hysteroscopically. We know this and we are repeatedly telling you this because going in with the dilator initially is going to start causing false passages, and you will not know where the niche is and what to correct because you'll have false injuries due to the dilator that you have used. Try and keep anatomical landmarks in constant view at all times. Your endpoint again is bleeding, pink, and both ostia at the same level. And when do you know you have false fibers? I think false passage, we've discussed this. But keeping in mind with a niche repair, you is likely end up with a very thin myometrial wall. So you should be knowing what is the depth between the serosa and the niche end. And if it's very thin, then this is, if you're correcting it for purposes of irregular spotting or bleeding, that's acceptable. But if this patient should have future fertility desire, then you are likely to end up with a very thinned out scar and risk of rupture during pregnancy. So a laparoscopic repair in that scenario would probably be better. Let's go into myomectomy, another procedure and one of the advanced procedures. But we would basically use myomectomy hysteroscopically for a type 0, type 1, and type 2 FIGO grading. How can we do it? We can use the scissors or graspers. We can use resection, and we could use a shaver. So the concerns we have with myomectomy is bleed, because if you are not in the right plane, then you'll start bleeding and that disrupts your procedure. Fluid overload, very likely if you open up channels. And as you're going on resecting and it takes longer and longer, the amount of fluid being used is going to be increasing, and therefore you have risks of fluid overload. Cervical trauma is possible. Perforation, very possible. Incomplete surgery, conversion to an open or a laparoscopic is likely. Chip management, when you're doing resection, those small chips that you're removing, managing them correctly to make sure that they don't collect in there and disrupt the view is important. Navigation within this cavity is a challenge, and leading to Asherman's after could be a challenge. So these are challenges or concerns with hysteroscopic myomectomy. Understand one more thing. Remember diameter and volume and time of surgery graph. So it's important to know that a 2 centimeter fibroid is not double the size of a 1 centimeter fibroid, and a 4 centimeter fibroid is not double the size of a 2 centimeter fibroid. It is very many fold bigger. So as you grow bigger from 1 centimeter to 2, 2 to 4, the volume of the fibroid and the amount of tissue you have to remove will significantly and exponentially increase, and that would lead to increased risk of surgical time, risk of Asherman's, risk of fluid overload, risk of bleeding. So you have to be careful when deciding. So if you're not an expert hysteroscopic surgeon already, be extremely wary of any fiber that's more than 2 centimeters. It's going to give you challenges excising the whole fibroid in one sitting, and you're likely to cause unnecessary complications. So either refer them to the right people or try and approach it laparoscopically. There's no harm. Remember, our eventual goal is to make sure the patient is safe. Timing again, follicular phase, to ensure that we see the lion in full, not in the tall grass but in short grass. Pre-op preparation like pre-op GnRH analog can be used. I've personally not used it for myomectomies, but it's an option. and it helps in a number of ways. One, thins the lining and might also help with reducing operative bleeding, and therefore with the reduce in time as well. Some of the tips from procedures of myomectomy hysteroscopically that I have done would be: one, yes, I have used the opium technique sometimes to prepare partially intrauterine myoma type 1s and 2s by excising the capsule around it and leaving it. And when you now go in, sometimes it could be even during the procedure itself, where I've done it while I'm doing the excision of the capsule, and then with some hydromassage where I have the distending media, and then I close the fluid channel so it goes that way, and I open the fluid channel, close the fluid channel, open the fluid channel, close the fluid channel, open the fluid channel, and that hydromassage pushes the fibroid that you've cleared the circumferential fibroid capsule towards the inside. So you realize that a grade 1 and 2 fibroid suddenly starts becoming grade 0, and then it becomes an easier resection than resecting into the cavity. Use scissors to release this myoma capsule. When you're doing a resection, please make sure you resect only on the myoma and its capsule, not into the myometrium. So you should be able to have the anatomical knowledge to tell you that this is myoma tissue and its sub-pseudocapsule, and this is now going into the myometrium. You'll see the layer. So if you see the layer, don't go deeper than that. Then you will not end up with bleeding, and you will not end up with Ashermans. Try and make long linear chips if possible. If you're using resection, then just small dig outs, because the more you make, they're going to disrupt your view. Use decompression and massage, as we've said. Type 0s and 1 are a bit easy. Type 2 can be difficult but may need 2 sittings, or sometimes, as I've said, you separate it out and with the hydromassage allow it to change from a type 2 to type 1, and then a type 1 to a type 0 for resection. Incomplete resection is not a sin, it's not a complication, it can happen, but just make sure you discuss this with the patient pre-op. If it's a big fiber and it's a type 2, you can tell her, I might do it in 2 sittings, and I will avoid a cut on the uterus from outside, and but I'll be able to remove your fibroid that's causing you the problem. So it's possible, but you have to discuss this with the patient prior, not after, because then they are not usually happy, because you told them you'll remove it and now you're saying, I'll have to take you back in. So, consent, discussion, mutual understanding, and informed decision making is very important. Limit resection, removal, and reinsertion of the hysteroscope all the time. So make sure that you don't have too many in and out of the hysteroscope. Your risks increase after this exponentially when you do repeated reinsertions and removal, including risks of embolism. Further to the tips, avoid resecting opposite side fibroids in one sitting sometimes. If there are multiple, should you do the anterior wall and the posterior wall together? Well, you can, but then you have to be very careful with how you're going to prevent the Ashermans of this uterus. You'll have to leave in a barrier in between. Or you could do the posterior wall in one sitting and then do a few weeks later do the anterior wall, and that might prevent two raw surfaces from sticking to each other. When they are large, sometimes you may have to bisect or quadrisect fibroids before removal. Resect only while advancing the electrode towards yourself, as opposed to activating it when it's going that way. So using passive resectoscope is sometimes safer than using the active resectoscope. But even if you're using active resectoscope, then resect towards yourself, not away from yourself. How do you take care of or control bleeding? You could use energy diathermy, pinpoint buzzing at the points where it's bleeding. You could use Foley's at the end and distend it and leave it. You could use intrauterine pitocin gauze packing, but it's difficult if you have a cavity that is, the cervical canal that is still that small. How are you going to put in the gauze and cause pressure? You could use embolization, you could end up sometimes doing a hysterectomy, which is going to be catastrophic because you're planning a myomectomy and converting it to a hysterectomy. Be very careful in this. It might lead to unnecessary medical legal issues, but to save a life, it may be necessary. It might be also possible to go in laparoscopically and stitch from the outside and reduce the bleeding so that you can avoid a hysterectomy. Adhesion prevention, technique. If you play with, even in laparoscopy, even in hysteroscopy, I think one of my biggest tips to avoiding adhesions is staying and operating within the right planes. If you operate within the right planes and you respect tissue, not mishandle tissue, not cause unnecessary damage to tissue, not cause dryness to tissue in laparoscopy, then you'll actually not leave too much bleeding. We'll actually not have adhesions. So in the hysteroscopic myomectomy, staying within the capsule is actually very important in preventing of adhesions. You have minimal injury to the myometrium, and you could use the barrier gel or a physical barrier with Foley's, and maybe use hormonal regenerative techniques with estrogen and progesterone sequential to help with regeneration of the damaged endometrium. And these are ways that I've seen have helped with prevention of adhesion. Now, if we have cervical stenosis, and this happens quite a lot with people sometimes following a DNC or a suction evacuation. When you damage the cervical canal, it closes up. We have seen it in very many postmenopausal or perimenopausal women where you'll have fluid collection because there's cervical stenosis. So there are different ways of approaching it. One, you will have to probably use sometimes the tip of the hysteroscope to guide you. You could use a 5 French grasping forceps or scissors in front of the instrument to dissect open and go under vision as you open up the cervix. Or you could use a 5 French bipolar needle and you would open up as you go ahead. Please understand the anatomy. The internal os is horizontal as a slit, and you'll have to open the cervix in a horizontal aspect, oval and not round. So that's how you're going to be opening up the internal os as you move ahead. Try avoiding false passage, keeping in mind that when you go into muscle fibers, the same way they'll be bleeding, then you know you're in the wrong plane. So follow the guide from the hysteroscope and under vision, use any of these techniques to open up the cervical canal. Sometimes you may need to go in under ultrasound guidance as well to guide you on the way ahead. There are others that we are not going into specifics about. There is Asherman insertion, there is tubal cannulation, there is IUCD removal, which I have not covered in this specific talk, but we could discuss it in a separate talk. There is pre-IVF hysteroscopy, and there was a role for endometrial scratch that has been done under hysteroscopic guidance in the past, but sometimes it's done just blindly. And we then have the endometrial ablative procedures where you have first generation, second, third generation, and now we have the surgical procedures which we were supposed to have discussed: rollable, the transcervical resection of the endometrium, laser endometrial ablation is an option, and these are not discussed in this specific talk. We might take it up separately. So this is an advanced technique and a skill that is required with proper appropriate training. Thank you very much. So this was to cover up hysteroscopic operative procedures. Should you have any other questions that you would want us to, or clarifications that you would want us to discuss, please write us a question and we will see if we can cover that in another video. Thank you very much and have a great day. Ciao from Third Park Hospital, Nairobi. Bye-bye.